As I begin to, I just want to recognize Nicole and the incredible work that she's doing through the Learn Body Literacy platform, gathering an incredible community of like-minded women coming from different countries, different walks of life, different socioeconomic backgrounds, just different life journeys, but having this one shared passion for centering our bodies and the power that comes with this knowledge of how we were designed. So with that, I'm just going to dive in. I have a lot of content today. I'm going to do my best to not speak obnoxiously fast, and we're just all going to do our best. I truly believe that everyone deserves to be taught to read the language of their body, not just middle-class white women, not just married women, not just those born into privilege, but every woman. The title of my talk is Body Literacy for All, and I have a bit of a philosophical streak, so I think it's important to begin by defining that term. What do we mean by body literacy? Simply stated, if literacy is the ability to decode signs and symbols and understand their meaning, and body literacy is simply the ability to understand and interpret the signs and symbols our female bodies are giving us every day, to understand what they mean. Just like letters build to words, and words build to sentences, and sentences build to paragraphs, and then a full story. In the same way, when we begin to attend to the messages our body gives us every day, these build into a story as well, one that we can begin to learn, interpret, and understand. No longer do our bodies appear arbitrary to us, but we can understand the intelligent design that is present there, and harness that power as we step forward in our personal journeys. Another definition that I appreciate is from a dissertation by a really fantastic Canadian woman named Angie Erico Fleming. She said, our bodies are communicating to us as women through our cycles, and our ability to understand this communication is called body literacy. The history of the term briefly, it was first found in the literature in 2005, attributed to Laura Werschler, then the executive director for Planned Parenthood of Alberta. She introduced the term body literacy, defining it as follows. Number one, learning to read and understand the language of the body. And two, learning to observe, chart, and interpret an ovulatory menstrual cycle. So what are the things that every woman deserves to know about her body? On a very high level, there's some foundational concepts that I think apply to men and women equally, right? We're an organic whole. To borrow a phrase from the reactionary feminist Mary Harrington in Feminism Against Progress, she says, we're not made of meat Legos that can be easily snapped in and snapped out at our will. We're a whole. And because we're a whole, everything is connected to everything else. Another foundational concept is this understanding that our body is intelligent. It's not just mere matter, but it acts together in coordinated, systematic ways for our good. And finally, that the body has the capacity to heal itself. When given the right support, our body is capable of doing incredible things. I also think the following points around female physiology are basic body literacy concepts that every woman deserves to know. She needs to know her anatomy. I worked with a sweet young woman once who didn't know she had 3 holes down there. She thought her urine came out of her vagina. She didn't know. We need to know that we have 4 distinct phases in our menstrual cycle. We need to understand our biomarkers and how they can tell us where we're at in the cycle at any given time. We need to know that while the red flow is the most obvious sign of our cycle, it's actually ovulation, signified by our white flow, that is the main event and the 5th vital sign, that sign of health for women. Contrary to popular opinion, women cannot become pregnant literally at any time, that we have a distinct window of fertility each month. And finally, we should understand the basic parameters of a healthy menstrual cycle and understand maybe things that are common but not normal, and when to seek help. And when we have this knowledge, then we have the foundational understanding we need to be able to discern the difference between just symptom management and actually treating the root cause. I just want to check in with the audience. I'm doing some things. Are you not able to see my screen?
Katie, I don't think they're able to see the screen. Can you try to share your screen one more time?
I sure can. It looks on my end as though I am, but I will try again. My apologies. Is this better?
I see it now. Yep, I think we see it. Thank you.
Okay, you literally have not missed much. Just words. Okay, perfect. Thank you for keeping me on track, everyone. The women who are literate of their bodies this way tend to center an approach to their own health and wellness that works with their body's design, that respects the reality that we're a unity of body and soul, not a ghost trapped in a machine. In a word, they tend to embrace a holistic paradigm of health. And again, what do we mean by that? That we're working with the body's natural capacities, not suppressing, circumventing, or overtaking them. Again, that the body has the capacity to heal itself, provided the right support. And that we're not just working to alleviate suffering and reduce symptoms, but our aim is wellness and human flourishing. Okay, so if this is body literacy, and this is what holistic health means, then I think it's safe to say that there's an attitude out there that this level of understanding and this kind of health is just for the privileged few. You know, the Bohemian Bourgeois people can live this way. Elites in California can live this way. But everyone, is the title of this talk really body literacy for all? And the answer is yes. I hope to be part of a change in women's health that removes barriers and increases access to body literacy and holistic women's health across the lifespan for all women. For youth who are more often than not deprived of the basic information about their bodies that is their birthright, that can change the whole trajectory of their future healthcare decisions. For the disabled, whose overall health is at times willingly compromised for the sake of convenience or traded off for the perceived benefit of protecting intellectually disabled women from an unplanned pregnancy. And for the poor, who through the paternalism of well-meaning healthcare professionals are often offered only non-holistic solutions to meet their menstrual health and family planning needs. We know in broad strokes that health illiteracy leads to greater health disparities for each of these populations. And if we really care about public health, if we really care about women, we'll pay attention to these disparities and look for ways to bring body literacy to all, especially those who are least likely to have it. So I want to dive in by focusing on 3 populations with you over the next hour or so. I want to talk about adolescents, intellectually disabled, and under-resourced populations. And I want to think together with you about body literacy dynamics around each group and about creative ways to bring body literacy and holistic healthcare options to these populations. So we're going to start talking about the youngest group, body literacy in adolescence. And I want to steal a page from the inimitable Lisa Hendrickson Jack, author of The Fifth Vital Sign of the Fertility Friday podcast. I'm sure many of you know her. In The Fifth Vital Sign, Lisa says this: to keep a population illiterate is an act of systematic disempowerment. If a population cannot read, they are all the more easy to use, abuse, and control. And so what does it mean that in our society, most women are kept illiterate of their own bodies? Is this not also an act of systematic disempowerment? If you want to look for evidence of this systematic effort to keep women in the dark about their bodies, at least here in the United States, our failure to prioritize teaching body literacy within educational settings, I think, is a good place to start. And yet, in our country, again, if you look at state by state health education standards, most only mention menstruation in terms of hygiene. And it's the same no matter the politics of the region. And if this is not evidence of a systematic effort to keep our youngest women illiterate of their bodies, I don't know what is. Puberty education fails to equip young women with knowledge of basic body literacy concepts. Again, it's a glorified hygiene lesson most of the time, without knowledge of how their cycles relate to their overall health, how their hormonal health affects their overall health. They are blind to the impact the decisions they are making in the present will shape their health and fertility in the future. They do not have the knowledge they need to understand what experiences may be common but not normal. And their time to treatment, if they are struggling, is often significantly delayed because of this lack of knowledge. For one example, the average time for a woman to be diagnosed and finally treated for endometriosis is between 8 to 10 years, depending on your source literature. On the family planning front, modern sex ed for adolescents tends to narrowly focus on teaching adolescents to avoid pregnancy. Whether the emphasis is on condoms and hormonal contraception, or the emphasis takes a more primary prevention approach and emphasizes abstinence, the message is the same. Pregnancy is bad, and it's something to be avoided at all costs. A more holistic education would reframe pregnancy as a positive power of a man and woman's shared fertility, something that occurs when two healthy bodies come together and a sign of wellness. We'd make certain that both young women and young men knew not only how to avoid pregnancy, but how to optimize their chances of conception when the time is right for them, within the context of their own reproductive life plan. But until very recently, adolescent education along these lines was few and far between. It was only in March of 2023 that the Department of Education in the District of Columbia issued the first of their kind menstrual health education standards. And they're really excellent standards that women should be able, by the 12th grade, to name the advantages, disadvantages, and environmental impact of ovarian suppression products. I think this is fairly groundbreaking. Some of these standards have been picked up by Massachusetts and are being considered by other states currently. I think it's a very exciting move. I've always been more of a grassroots person myself, and there are plenty of others working to bring body literacy education to adolescents through family and community. And I'm excited that there are some in leadership looking at top-down solutions as well. To that end, recently I soft launched another little project, the Body Literacy Project, with the aim of working with both leaders in policy and in education to bring body literacy education to American students at large. I'm excited to be piloting a model curriculum through the Advancing Body Literacy Education Project in partnership with a grant through Duquesne University and in collaboration with the School of Medicine there. We have lessons for both adolescent women as well as adolescent men, and you can learn more at thebodyliteracyproject.org. In the next part of my presentation today, I want to talk about body literacy and women with intellectual disabilities. What happens to these women? What about holistic health for these individuals, given all of the complexities surrounding the intersection of their normal desires for intimacy, marriage, and family, and their intellectual disabilities. This could be a talk all of its own, yes. It's of interest to me personally because my own daughter, Mary Claire, now age 12, has an intellectual disability. But when Mary Claire was just 8 years old, a personal encounter with our summer nanny opened my eyes to some of the dynamics around reproductive health care for women with intellectual disabilities. Here's what happened. Our nanny had a younger sister named Anna. Anna struggled with a seizuring disorder that also came with an intellectual disability. And she was really struggling with heavy bleeds and difficulty managing hygiene, especially at school. Her mother was actually a women's health nurse practitioner and decided just to deal with the hygiene that she wanted to try an IUD with Anna. So an IUD was placed, and within a couple of days, Anna's seizuring disorder went bonkers, absolutely berserk. Our nanny came to our house fairly stressed out on behalf of her sister. And I just wondered out loud if the fact that her seizures were provoked maybe had anything to do with the IUD placement. We know that hormonal contraception doesn't just hit the target, but that we have hormone receptors in every cell of our bodies. And it's very possible that these things were related. And it hadn't occurred to my nanny's mom, again, a nurse practitioner, that it was possible that there was a link here and something to be explored. And I don't know what happened next, but I do know that this experience got me thinking about what I wanted for my own daughter when it came time to face these realities. As I dug deeper, I didn't like what I found, friends. I think we have to be clear-eyed about the history of women's health and this population specifically. Reproductive health care for women with intellectual disabilities has been influenced by prejudicial views about their sexual behavior and parenting capacity, eugenic-based ideas, which manifested themselves in forced sterilizations and institutionalization with strict segregation of the sexes, left a historical legacy. Many myths and prejudices still remain about the basic undesirability of women with ID to be mothers. These beliefs had led to contraception sometimes being given to women with intellectual disabilities in a very heavy-handed way. And to flesh that out a little bit, the most commonly prescribed method of contraception for women with intellectual disabilities is the pill, at about 40%, and Depo-Provera is a close second at 34.2%. The third most common method cited in this particular study I found out of the UK was the IUD. Healthcare practitioners and others who support women with intellectual disabilities, I think, have a responsibility to outline both the advantages and disadvantages of any given method of contraception. The disproportionately high use of Depo demonstrated in this research and elsewhere leads us to question whether this is always done in practice. Depo-Provera is most commonly used by women in the general population, only by about 3%. And so if you look at that, it's being prescribed at 10 times the rate for women with intellectual disabilities, and often with no care towards the devastation that this wreaks on women's bone density over time, and many plethora of other unintended side effects of Depo. Women with cognitive disabilities were 1.5 times as likely to undergo tubal ligation and 2.5 times as likely to have a hysterectomy compared to peers with normal abilities. And they were likely to undergo these procedures at a much younger age. The average age of hysterectomy for women with ID is only 27. This is my daughter. This is my Mary Claire. And when I think about what I hope for her, I want her to know that her body is good, that her cycle is the center of her health, and that we want to work with the brilliance of her body. Her body is still brilliant, even though she struggles in certain ways. She showed signs of precocious puberty. It didn't happen. She didn't start cycling until just recently, actually, but we prepared. And I created a really simple pictorial cycle chart for her. She has 3 colored pencils. She has red for red flow, blue for her white flow because of the connection with moisture. So there's a little drop of water to remind her about her white flow. And then she has yellow for anything else that she might sense. And she is able to track her cycle, everyone. She's completely capable. And I just think even when the disabilities are more profound, we can come up with creative ways to assist women, even women who are nonverbal, to know where they're at any given time, to understand when they may be experiencing menstrual distress, and to bring a restorative approach to their healthcare aimed at, not just suppressing their symptoms, but actually helping them heal. If you want to learn more about some of these practices and just more on this topic, I had the pleasure of joining Jamie Rachi and Teresa Kenny on the Hormone Genius podcast recently. I think it's called Puberty, Literacy, and Intellectual Disabilities. So you can do it there. Before I move forward from my gorgeous daughter, I want to share a family anecdote. She was nervous about changing pads. She has a really high sensory threshold and just doesn't feel things. So she didn't know if she would notice when she was menstruating. And so we decided period underwear was going to be a great way of managing in the beginning. So we went online and she got to pick out the pairs she liked and the cute design. She picked polka dots, and it was delivered on our doorstep. And my husband unsuspectingly came home, saw this package, brought it inside and said, "What's this?" And Mary Claire jumped up and said, "Daddy, that's my period underwear." And the time kind of stopped in my house. It was the first time that it was acknowledged that my daughters are going to menstruate. Everyone knows mom has the bleed, but the girls are going to bleed. And how is dad going to handle this? And all eyes were on him. And I'm happy to report that I'm married to a fantastic man who remembered who he was and what he was supposed to say in that moment. And he just gathered her up in a great big hug and said, "That's right, Mary Claire, these are your period underwear." This really normalized an experience that can be really shaming for a lot of girls. So I hope that sets the tone for my other daughters and is an encouragement to many of you. All right, we're going to spend the last chunk of our time talking about body literacy in under-resourced populations. We could probably write an entire course and still not cover everything there is to say about health disparities, body literacy, informed consent, and this particular population and the struggles that come with it. To give our time today some focus, I want to zero in on disparities related to fertility awareness-based methods of family planning in under-resourced populations. I understand that fertility awareness is not for everyone. When we understand the science, though, behind these methods, as well as the way their use is associated with any number of positive public health outcomes, we would expect fertility awareness to at least be included as a viable option in patient-centered contraceptive counseling. And yet, it's the case that use rates are incredibly low. They're hard to, but according to the latest data from the CDC, 2.2% to 3.2% of sexually active women use a fertility awareness method. And this number dives even lower to lower than 1% when we're looking at women who are utilizing federally qualified low-income clinics and also Title X clinics. Yes, I can say what FABMs are again. Fertility awareness-based method of family planning. And I should define my term just in case, just bring everyone along. So what we're doing is we're using our knowledge of our bodies to track the daily signs and symptoms our bodies give us. So we can know with precision where we are at in our menstrual ovarian cycle, and we can determine on any given day whether we are fertile or not fertile. And then it's a behavioral method of family planning. If you are trying to conceive a child, you know exactly when to make love in order to optimize chances of conception. And if you are seeking to avoid a pregnancy, you know what to do at that point as well. So as an umbrella term, there's many different methods that are included in this class of behavioral methods, but the acronym that's used in the literature is FABM, Fertility Awareness-Based Method. Thanks for asking for the clarification. We know that working with our body's natural design is incredibly empowering and has many positive effects on women's health. And yet the use rates are abysmal. They're incredibly low. And I think it's worth asking like this simple question my children ask me every day about 1,000 things. Why? Why is it that these use rates are so low? As we unpack this, I kind of divided it into two parts. We first are going to consider both physician-related and patient-related factors related to these low use rates. And then we want to hone in on, not just diagnosing the problem, but what can we do about it? How can we better connect the power of fertility awareness to under-resourced and underserved populations? This is a graph from a paper that was published in 2020 exploring attitudes towards FABMs among healthcare professionals within Title X family planning clinics. And it revealed that the majority of clinicians felt neutrally towards fertility awareness, while nearly 42% of respondents stated that they believed either moderately or strongly that fertility awareness methods were a non-viable option for most women. So either we're ambivalent or we see it as non-viable, and that accounts for the vast majority of those serving in these federally qualified settings. To add a bit of color and context to these attitudes, I want to share an anecdote I first encountered in Jennifer Block's 2019 book, Everything Below the Waist. In her chapter on family planning, Block interviews a certified nurse midwife named Amy Willen, who serves in a nonprofit clinic on Chicago's West Side. Willen brings up a hard truth, namely that fertility awareness requires sexual agency, and clinicians are often faced with clients who lack it. Willen said this: obviously, there are better things than hormonal birth control. There are healthy relationships. There's tracking your cycle, she says. But I can't undo centuries of oppression in a 15-minute appointment. What I can do is give her something that will help her not come back pregnant in 6 weeks. Willen agrees that in this context, hormonal contraception is a method of harm reduction, not exactly empowerment. I share this story because I think it's powerful, and I think it cuts to the heart of many of the dynamics and hard conversations around fertility awareness. While I see Ms. Willen's point, I understand where she's coming from. If I could speak to her today, I would respectfully respond in at least a couple of ways. First, I would ask her, how do you define harm? Is it only in terms of unplanned pregnancy? And if so, then to be fair, we need to point out that even if her patients do walk out with a year's supply of hormonal contraceptive pills, some women will still come back pregnant in 6 weeks. Why? Because hormonal contraception is not 100% effective. And it exposes the woman to other kinds of harm that she may or may not be knowledgeable about. These methods are associated with a myriad of side effects, including increased risk of blood clots, depression, breast and cervical cancers. And is Ms. Willen taking time to ensure that her patients have truly informed consent around this decision? Do they understand first how their bodies work in a state of health, and that hormonal contraceptions work by actively suppressing endogenous hormone production, affecting not just their ovaries, but every cell of their bodies? Some may still choose hormonal contraception, but can we at least work to ensure that they're choosing it in the context of actual informed consent? Second, in response to Ms. Willen's statement, I'd point out that if she's focused, that she seems to be focused on women in unhealthy relationships, and that for youth and low-income patients, hormonal contraception then becomes a form of harm reduction. And I acknowledge her good intention. At the same time, I would ask her if she could see it both ways. I see the potential of contraceptives to reduce harm to women in abusive relationships. I also see it another way, that it is possible in these hard circumstances that hormonal contraceptives transform a woman into an object of use, perpetuating the very cycle of abuse we would all hope to be part of ending. As an educator myself, I would say to Ms. Willen, I understand that behavioral methods are not for everyone, but when I don't even present fertility awareness as an option, I'm not even giving this woman a choice about whether she wants to choose actual empowerment or not. The German philosopher Goethe said, "The way you see people is the way you treat them, and the way you treat them is who they become." If I don't see the woman in front of me as fundamentally capable of using her voice in her relationship, maybe for the first time, she's not going to see herself as capable either. She may still choose a hormonal method, but that choice will be made again in the context of actual informed consent. As an educator, I don't think our goal is ever to take away access to a wide variety of contraceptive options for women. Rather, I think our goal is to promote greater participation in the decision-making process from our patients and to make certain we are truly presenting women with all their options. I believe that truly patient-centered care means supporting a truly informed consent. And to ensure informed consent, we must first ensure that our patients understand how their bodies work in a state of health in the first place. There is no informed consent without body literacy. Full stop. And what if this woman does choose fertility awareness? Though, of course, more research is needed, we see how this choice becomes associated with any number of positive impacts on health. There's some exciting research being done right now by Dr. Sarah Hill, author of the book, This Is Your Brain on Birth Control, and her newest work, The Period Brain. She's looking at the way that the combination of body literacy and an active cycle chart increases measurable reproductive health self-efficacy scores for women. So that just means how confident a woman is in advocating for herself in both her intimate relationships and in her healthcare. And this we find, which seems like kind of obvious to any woman who's ever charted her cycle, that her score increases. She gains confidence in taking charge of her own health, her fertility, and she finds her voice in bringing her goals and needs to her relationship. This holistic approach to family planning creates a certain context that sets women on a path that leads towards this health, wholeness, and healthier relationships. Which is fascinating, right? Because that tends to be the crux of why many in public health are hesitant to recommend fertility awareness in these hard situations in the first place. So shout it from the rooftops, friends. And, that cycle tracking increases reproductive health self-efficacy. And then this kind of catch-22 just dissolves. When it comes to family planning, I think that we want to explore the patient-related reasons why we have these low use rates. And I think we can sum it up in a really simple sentence. That simply put, women don't know what they don't know about their bodies. Many women don't even know that this form of family planning is possible. But when they become aware, studies show that they are very interested. A study of Hispanic women in Arizona found 61% of participants were likely to use fertility awareness to avoid pregnancy, while 50% would consider using fertility awareness to achieve pregnancy. Again, I think it's helpful to tell stories and share anecdotes. I met a young woman, we'll call her Sophia to protect the innocent. I met her on a women's health retreat. It was actually Adelaide Meadows' Radical Pelvic Health Intensive. Changed my life. That's a story for another time. So Sophia was struggling with moderate to extreme menstrual health problems through her teens and her 20s. And she agreed, working with her OB, to just try an IUD. From the start, she experienced many side effects after having that IUD placed: increased bleeding, headaches, mood changes. And she no longer, if you've ever had an IUD, you know it paralyzes your cervix. Your cervix can't move. And during the physiology of arousal, the cervix, we experience cervical flight, right? The cervix draws up in and elevates inside our internal pelvic tissues, creating more room for penetration with our partner. This couldn't happen anymore. And intimacy with the IUD became extremely painful. And don't even, no chance of orgasm. It was positively painful. She tried multiple times to get her healthcare provider to remove that IUD and was told that she needed to just give it more time. Her side effects were likely to subside. A very relatable experience for many of you, I am sure. When things did not improve after 3 months and she continued to be brushed off by her doctor, Sophia and her partner decided to take matters into their own hands. They watched a YouTube video and removed the IUD themselves, as one does. Sophia shared that she felt empowered, elated even, and then was immediately followed by the desire to swear. She's like, now what? What do I do now? After turning back to condoms and withdrawal, she eventually found fertility awareness on her own. She was able to successfully begin charting her cycle and then was able to use her chart as a diagnostic tool, connecting with a healthcare professional trained in restorative reproductive protocols aimed at treating the root cause pathology that caused the symptoms that drove her to agree to the IUD in the first place. Sophia is not alone. There are so many who feel they have no choice between hormonal contraceptives and menstrual distress, who are dissatisfied with conventional methods of family planning and just not aware that fertility awareness is even an option. Sophia is now a committed fertility awareness user, has successfully postponed pregnancy for the last 4 years using a symptothermal method. She was married last year, and now she's empowered to use the same knowledge of her body to achieve a pregnancy now that the time is right for her and her partner. This is another great strength of fertility awareness in federally qualified settings. We offer so many options for low-income women to avoid pregnancy, but are we doing anything for those who want to start a family and are having difficulty and can't or won't head in the direction of IVF? There's a lot of anxiety among our Generation Z and the later millennials. There was a really interesting article in The Guardian recently on fertility anxiety, that just looking to the future, even though the time's not right now, just this growing fear that we won't be able to conceive a baby when we want to. And fertility awareness really heads that off at the pass. I think to sum up this section with another quote, just you can't desire something for yourself unless you can first imagine it. And that we can play a role, those of us serving as educators, serving as healthcare professionals, and even just woman to woman, in helping others imagine themselves as successfully using fertility awareness to achieve their family planning goals. We can empower them with this targeted education, and then we can connect them with resources to support that decision. I think my slides are a little out of order. You have to forgive me. I think that in a clinical setting, shared decision-making must become the paradigm over and above all others for how we enter these family planning consultations. We want to recognize that there is a power differential that exists when we enter a clinic. And at times, this power differential has been misused. A study by Dahlendorf reveals that women have the greatest satisfaction with their encounters with healthcare professionals in the context of family planning appointments when the healthcare professional actively works to neutralize this power differential through, guess what, body literacy education and a shared decision-making process. While motivational interviewing techniques can be very effective, they can become manipulative if we end up employing the technique to persuade a woman to accept a method of family planning that we think is best for her, that aligns with our values for her. Over time, this tends to erode women's trust in healthcare in general. Minorities, especially Black and Spanish-speaking Latinas, expressed distrust of healthcare professionals based on experiences of past discrimination. And as a result, they tend to be less receptive to education, especially if they do not first feel heard and understood. In contrast to this deformed version of motivational interviewing, shared decision-making models create space for women to identify what she values in a method of family planning. And then, guided by her values and always with her permission, we can then offer targeted education with her values, serving as our point of reference. I have found it helpful to present women with a list of things they might value about a method of family planning. And then once she's uncovered what matters most to her, I'm not like spitting everything I know about fertility awareness at her. I'm speaking to her life experience and to what matters most to her. When we use a shared decision-making process and a shared decision tool within a clinical setting, we find increased patient satisfaction with both how the process unfolds, and we see a greater persistence in the chosen method afterwards as well. There's better outcomes. In most federally qualified settings, we know that many of our patients who may be interested in a natural method may not have the time and ability to receive lengthy instruction in some of the more comprehensive fertility awareness methods, such as Just-Cease, FEM, NEO, or Marquette. They need something that's more streamlined. I like to say they need the ninja version, something that can be taught and learned quickly and easily. Likewise, it may not be practical for healthcare professionals serving in these low-income settings to become a certified instructor in a comprehensive method. In order to remove these barriers and increase access, something else is needed. My friend and dear colleague, Meredith Krutar, a nurse practitioner from Helena, Montana, she saw this gap, and in collaboration with Title X in her state, developed a resource called the FABM Clinical Toolkit. You can learn more at fabmtoolkit.com if you're interested. And it's just a one-of-a-kind resource. It's meant to be an open and go field manual that provides clinical protocols for nurses for 4 simplified fertility awareness methods, 3 of which were developed by Georgetown University specifically for under-resourced populations. She has protocols for the standard days method, the 2-day method, which is a simplified cervical fluid method, lactation amenorrhea method, and then she developed a clinical protocol around natural cycles, which is an app-based algorithm press temperature method. I think it's really a brilliant tool and has great potential to better facilitate fertility awareness instruction in these under-resourced settings. You may well desire in a clinic such as this to have someone on your team trained in a comprehensive fertility awareness method. And again, if this is not feasible, there's many people offering instruction, even virtually. You can develop a pipeline to comprehensive instructors, as well as to telehealth clinicians trained in restorative reproductive medical practice. As we wrap up today, I just want to make a few points. Without body literacy, there is no informed consent. Right? It is the essential foundation for patient autonomy, informed consent, and holistic healthcare. I truly believe this is the heart of the matter. Again, we want to think about that differential of power and who is the expert. Is it the healthcare professional? Or by sharing this information that is every woman's birthright, then she becomes the expert in her own experience. And the role of the healthcare professional come alongside and collaborate with her. Truly, I think body literacy is the foundation of self-advocacy. If women don't know how their bodies work, they can't protect their health, make informed decisions, or advocate for the care that they deserve. Education is empowerment. Patients cannot seek or advocate for holistic care that works with their body's design if they don't first understand what health actually looks like and feels like in their own bodies. They don't know what to look for or ask for, because at the end of the day, you cannot protect what you do not know, and you cannot advocate for what you do not understand. But when you can, you're positively empowered to be the heroine of your own health journey. And this is my dream for all women. This is the cultural shift in women's health that I am working to spark alongside so many others. And this is, I believe, the movement that you all are a part of by showing up today and spending time on a frigid Saturday thinking carefully about this topic. So I'm excited about the future and excited to continue to work alongside so many of you. If you are interested in learning more about some of the resources that I have to as well, I just www.katievidmar.com. You can reach me through text on the screen here. My email address is very simple, katie@katievidmar.com. I am, as you see, on maternity leave technically, but when I come back, I'm excited to be launching a website called Cycle Informed Care. We'll be offering a certification for healthcare professionals in cycle informed reproductive healthcare, where we are teaching basic body literacy concepts, cycle charting, cycle chart analysis, and making that strong referral to the next level of care for women with reproductive health concerns. And yes, it's coming by the end of the year. So very excited to watch that grow and grateful for the chance. Again, Nicole, to be with all of you today. I would be happy here with the last 10 minutes we have to open it up to any questions.
Thank you so much, Katie. That was amazing. Yeah, just jump right in with questions. If anyone has them, feel free to get on the mic.
I have a question.
Yes,
Hi, everyone.
please. Hi,
I
Claire.
wanted to ask more about how you co-created the chart for your daughter to track her cycle. That's really interesting to me because I used to work in pediatrics and we focus so much on getting kids ready for school and sitting still in class, but I never thought about puberty and girls with intellectual disability and how, especially girls on the autism spectrum, and how that could impact everything. So that was really interesting to me. And I just wanted to know, like, what was that process like? Was there like a first iteration, second iteration? Did it work the first time? How did you tweak it? Things like that.
Great question. Thank you so much, Claire. So the method of fertility awareness that I'm trained in specifically is the Billings ovulation method, kind of like the grandmother of all of the modern fertility awareness-based methods. And it's a cervical fluid only method. And it focuses first and foremost on the sensation that a woman has at the vulva. They say, pretend that you're blind. And this is the most important biomarker that tells us where we're at. So with that in mind, I thought, my daughter can do that. she can begin to notice these most basic changes. And she's not able to read. Her mind is amazing and incredible. She has the most fantastic memory for some things. And then you give her a word like cat and she can't sound it out. So I knew that it needed to be really simple and doable. And I wanted her to do as much as she could for herself and then have that, be there to support her where she needed it. So, yeah, the first one, I went into Canva and I just made like a circle for every day. I put 40 circles on a piece of paper and I took like 3 different icons, one for bleeding, one for slippery, and one for dry or pasty. And I just matched them with the color. And I gave it to her like a coloring page and said, here you go, baby. Every night you get to color something. And so it's not perfect, right? She misses days, just like those of us even charting with apps that remind us we'll miss days. But it's worked really well so far.
Thank you so much. That gives me so much like of a place to like jump off from. So thank you.
Yeah. If you would like a template link, let me know. Just shoot me an email and I'm happy to share it.
Okay, will do. Thank you.
Yes. Any other questions?
I just had a quick question about something that I missed when you were talking about the last woman with the IUD. And you said that she was able to find a practitioner, and all I got was restorative, reproductive, and then there was a third word after that.
Yeah. I've probably used lots of different ones. Restorative reproductive medicine.
Oh, okay.
Is the umbrella term that is being used for an approach to women's health that seeks to restore the woman to her natural cycle, rather than symptom managing reproductive health conditions through suppression, symptom management, circumventing, etc.
Great. Thank you so much.
Yeah, there's 3 main modalities. There's the FEM modality. They have a medical management branch. With FEM, they have a whole network of telehealth clinicians who serve across the country and internationally. There's Neo-Fertility, which was founded by Dr. Phil Boyle in Ireland. And then there's the Creighton model of NAPRO technology. And they also train surgeons for endometrial excision surgeries, from women with PCOS who are trying to conceive and struggling. There's an ovarian section procedure that has been successful for many. They can help clear blocked fallopian tubes. But again, the whole aim is to protect bodily integrity and to restore natural function.
Wonderful. Thank you.
Yeah, thanks for your question. Anyone else?
I did want to also thank you so much for your talk, and to just get a little bit more from you about the, I think you called it shared decision-making process. I really like what you had to say about that. Could you expand a little bit about, I guess, how that could be used in a context where maybe the person's already had some experiences with different contraceptives, they've been bouncing around, or they're just maybe struggling with a reproductive health issue? How can that decision-making process help sort of those more complex cases? Yeah, thank you.
Absolutely, that's a great question. I think so often healthcare professionals feel pressured to come in with an answer and a solution. And I think it's all about training healthcare professionals to start with really good questions and empowering them with the right questions to ask, to really evoke from the woman what's her motivation, right? Like what does this woman need and want? And then once we've really attuned ourselves to that, to her values, her needs, and her wants, then we can start targeted education that's going to meet her where she's at. Especially, as you said, if she's already been on a long journey and she's already burnt out of meeting with healthcare professionals and she's already lost some of her hope that wholeness and flourishing is possible. And I think, there are some fertility awareness methods, some cycle charting practices that are going to draw out more clinically relevant information. And just like before you are referred to the GI doc, you have to do that bowel and bladder diary for a whole week before you can see the specialist. In the same way, the more clinically relevant information we can pull together around our female cycle before we see that restorative reproductive medical clinician, the more quickly they'll be able to help us. And so I think part of the hurdle is training your nurses, your nurse practitioners, your family practice docs, those frontline healthcare professionals, how to help women start tracking this clinically relevant data so that if they want to take the route of root cause treatment, they don't want any more symptom suppression, that we're equipped to help decrease that time to treatment effectively.
Amazing. Thank you so much. And I'm going to stop the recording here. If anyone has any other questions, they're welcome to hang out in the room, and in the chat, I'll put the next room. Thank you so much, Katie. Really appreciate you.
You're welcome, Nicole. Thanks for the opportunity.